Yeah, of course, happy to talk about TSC in adults. This is some of you, I'm happy to answer questions. I think it's a group that we don't talk about as often, but it's an important group, and I think as we learn more about TSC, as we become better at diagnosing TSC, it's clear that actually the majority of people with TSC are adults. They aren't kids. Um, so I'll try and present that perspective a little bit. So just to say that, this is I included this in the recent presentation. I found this and I decided to include it today. So this is a list of all the TSC clinics, the recognized TSC clinics in Canada and this part of the US. And you see there are quite a number of them and quite a number of them in Canada as well. But then when you look at which are the clinics that follow adults, well, actually, there are only two of us, at least the more official and more organized ones. I know there are other people who do follow TSC, but the more official organized TSC clinics for adults are the one at the CHUM in Montreal, and then my colleague in London, Ontario, so Andrew House, who runs a TSC clinic there. So in spite of the fact that most people with TSC are in fact adults, there aren't very many clinics. To just talk to you a little bit about how TSC clinics in adults run. In terms of the medical care, it really runs in a way that's similar to the way most pediatric TSC clinics run. We actually had a meeting in Montreal not too long ago. We were all talking about the way we each run our clinics. I think we mostly do it in the same way, in that the neurologist, usually it's a neurologist. In a few cases, like my colleague in London, Ontario, a nephrologist, uh, becomes the main pivotal individual that are running the clinic, becomes the main resource. It's that one person who actually follows all the patients with TSC, that it becomes what we refer to as a virtual multidisciplinary clinic, because it isn't a clinic where you arrive and then there are multiple doctors, you see one after another, but rather there is one doctor, and then that doctor follows everything. That doctor is the one who's doing all the screening, but then of course knows when it's time to refer to the relevant specialist. So in adults, in fact, that specialist is most often, that other person will most often be someone to look at the kidneys. And we'll talk a lot about the kidneys today, to this evening. But so someone to look at the kidneys at my institution, that person is the urologist, so a surgeon of the kidneys. In other institutions, it could be the nephrologist, who is the more commonly sought person. I know at Saint Justine in Montreal with Philippe Major, it's more often the nephrologist that is his go-to person, the person that is helping him with managing the kidneys. But at CHUM, it's the urologist. And then we have other individuals who to whom we refer our patients. We make sure that it isn't just any old respirologist, any old geneticist. We want to make sure that it's always the same person. That way, it's people who we know and who know how the way we work, but also then it becomes someone who sees a lot of TSC. It is a relatively rare disease, and so you want to make sure that everyone on the team has a certain degree of experience in it. And the only way to do that is to concentrate care, make sure it's always the same person. It makes a difference. I like this is a classic saying in pediatrics. So Dr. Whitney is a pediatrician, so I'm sure she's even seen this, probably the same slide, that kids are not little adults, which is certainly true. This is often made, the comment is made because we'll assume that a medication or an intervention that's proven to be efficacious, effective in adults, well, then it must work in kids, not necessarily, or not necessarily in the same way. In the context of TSC, I think it's fun to point out that we're actually coming from we're looking at things in the slightly opposite way, because of the reason of the understandable traditional focus on kids with TSC. It's important for us to emphasize that adults are not just big children. We published, we did this a few years ago now where we just wanted to describe what adults with TSC looked like. And, um, and this was looking at people in Canada. And you see here, I'm not going to go into the details, but to emphasize that, and we didn't compare here to kids directly, but I can tell you that adults with TSC, that there is intellectual disability, but it isn't all of our patients. In fact, it's not even the majority of our patients. In fact, we right now are, some of you know of how we're or are participating in a cohort that we are have been building over the last year and a half or so of people with TSC, mostly adults. And in fact, intellectual disability in our current cohort of 105 people or something, it's in fact only in about 30% of our patients, of our participants. So very different from what would be the image you would have of TSC when you're reading, especially older textbooks. That we have patients, we have a lot of patients who are seizure free. I have patients who've never had epilepsy. It's very important to understand that the tumors that we see in TSC, although they can appear to be random, in fact, they still do follow relatively predictable and reproducible patterns between individuals. So they follow certain patterns, and especially associated with age. So, for instance, and this is from a classic study in 2017. For instance, the cardiac rhabdomyomas, we see here each bar for each different tumor type represents an age group. So the taller the bar, the more common it is in that it is in that age group. And so we see here for the cardiac tumors that all the tall bars are the ones in the young kids, right? And that's what we know. We see that. It's that cardiac tumors are a problem amongst the neonates. It's the problem in the first year or two of life that, in fact, the majority will start spontaneously regressing within those first few years of life. And it's relatively rare that I'll find an adult who still has evidence of their old cardiac rhabdomyoma. They're usually gone a long time ago by the time they get to me. And that's common. That's a pattern that we see over and over again. A pattern that we see over and over again is that SAGAs, so these tumors in the brains that can develop in the brain, the reason why we do all those frequent MRIs of the brain, well, that's an issue in childhood and adolescence. But then once you start reaching adulthood, once you start reaching your late 20s, going into your 30s, it's very rare that that is an issue. We decrease the frequency of MRIs of the brain in adults for a reason. They're just not needed. It's not impossible. Of my 150 people that I follow, I know one person where there was something that happened when they were older, but that's one out of 150. It's by definitely the exception. So what we do see though in adults, what you see how the bars grow taller as you grow older. What we see in adults are the kidney problems a lot, and then to a lesser extent, but still very associated with age, are the tumors that affect the lungs. So these are the two important tumors for us in adults, the new ones, the ones that are growing, the ones that will change in adulthood. It's those that affect the kidneys. Oh, I forgot to translate this, sorry. So the kidney tumors, which are here on the left. So here you're looking at, these are not normal looking kidneys. These are meant to be kidneys and they are being infiltrated by large other tumors. And those that it's a lot less common, but again, it's an issue in adults is these are not normal looking lungs. All right. So there's a few words on that. So the renal AML, so the renal angiomyolipomas. So this is it. It's common. So and it becomes more and more common with age. So you won't necessarily, and often you won't have it when you're very young, when you're an adolescent. But then once you're in your 20s and your 30s and 40s, it's quite common that you'll develop some new tumors inside the kidneys. They're not a cancer. That's not what we worry about. We don't worry about them spreading to other organs, metastasizing. Uh, they, in fact, generally have very little impact on renal function. So the kidneys continue to work perfectly fine. You can do all the regular kidney tests and they never change. And I've had patients with huge AMLs, and their kidneys are working perfectly fine. What we really worry about is that when they're often very fatty, but often they also become very vascular. They have these blood vessels, and they're fragile, abnormal blood vessels that can also develop aneurysms on them. And so the concern is that they can bleed. And when the kidney bleeds, it can be dangerous because you're bleeding within the abdomen, you're bleeding behind the abdomen, and that's a big empty space, so it's easy to lose a lot of blood there. It's not like bleeding, say, a bruise within a muscle. Well, all that tension is going to keep the bleeding to a minimum, and in fact, will help the bleeding stop. In the abdomen is just this big open space, and so that's what we worry about. The the tumors affecting the lungs are far less common. So instead of going up to 80%, it's 10 to 15% of women, of females. It's very rare to see it in males. It can happen, but it's rare. I have, I think, one patient with it. Um, and it's much more frequent in women. We think there's an influence from the hormones. Female hormones increase the likelihood of these cells surviving, of these cells spreading to the lungs, of this happening in the lungs. This is one of the reasons why we strongly recommend against exogenous, so taking extra hormones. So, because the thought is that they probably increase the risk of developing these tumors in your lungs. So we recommend against the pill, a contraceptive pill, recommend against hormone replacement therapy. Um, yeah, these can affect lung function. And so once we do find them, then I will ask my respirology colleagues. They'll do dedicated tests of the lung function every year or two. Uh, and one of the things here, so we're worried about how they affect the lung function in general. They also can predispose you to what we call a pneumothorax. The classic story is that this can happen during pregnancy. So the woman with TSC becomes pregnant, and that hormonal environment favors the growth of these tumors in the lungs. They are very cystic. When they're near the surface, they're fragile, and if that tears, then it leads to an air that can escape outside the lungs, and it escapes outside the lungs, but still within the thoracic cage, within the chest. And so then you have air out between the lung and the ribs. And then that actually keeps the lung from being able to open up properly. It becomes trapped and stuck as a small thing. And that's what we don't like. That's the danger. It's easy to address. They're easy to address, but it needs to be addressed. It's not something that you can just leave on its own usually. And this is what we worry about with these things. Um, I should mention, I don't think I have a specific slide on it, but both of these are very treatable. And we know about them, we think about them so that we can prevent them from happening. And that's why we do all the imaging so that we know know when to start. And the classic treatment being everolimus or sirolimus, so that we can prevent these complications so that it just doesn't ever happen. So because of these things, we have to image, we have to screen, and this is the screening schedule that we use at the CHUM. I've never translated it into English. I apologize. I should do it one time eventually just for the presentations. But here, what I will mention, what I'll emphasize is that this is just it's just a reiteration of what is recommended in this document. So this is what we all pretty much follow in terms of the screening schedule, how often you have to do an MRI of the brain, how often you have to do a CT chest, a CT of the lungs, and so forth. What I will mention is that these are they're fairly, they try not to be too much, but they still are, I think, more focused on kids than they are on adults. I can tell you that we don't do regular dental exams. At least the clinic doesn't try and organize the dental exams. We don't organize ophthalmology exams. It's unusual it would be uncommon for an adult TSC clinic to send its patients to the ophthalmologist for regular exams every year or so. That's common in kids. It's important in kids up to, if I understand, and Dr. Whitney may correct me, maybe her practice is different, but I understand from Dr. Majal at Sage, he does that regular ophthalmology exams is especially only up until 6, 7, 8 years old, and then it starts becoming less frequently done after that because it's just not necessary. Um, and another thing that is different that we do differently in adults is we decrease that frequency of those brain MRIs. So they're done every year or so when you're a kid, and it'll be done like that for a long time. But once you're an adult, especially once you're past 25 years old, and you certainly, if you don't already have what we call a SAGA, those tumors that we worry about, what they can do to the flow of cerebral spinal fluid around the brain. If you haven't developed one by the time you're 25, the chances that you're ever going to develop one are very low. And so we don't need to do as many MRIs of the brain. It's one test we can save. All the better for the patient, for the comfort of the patient. Um, when I'm talking about adults with TSC, I often mention everolimus and what we do in the long term. I think it's less of an issue in kids that once the everolimus is started, it's my impression, and again, correct me if I'm wrong, my impression is that most of my pediatric colleagues don't try and stop it while they're being followed on the pediatric side. Um, I'm not in a rush to stop it either because we have nice data suggesting that everolimus, even long term, so years and years later, is safe and remains effective, certainly, but is safe. But at the same time, if there are things that we do take into account. For instance, if the only reason you're on everolimus is the brain tumor, the SAGA, well, once you've passed 25, I know that the just the biology of what's going on in your body is working in our favor. Your SAGAs aren't going all by themselves, they will stabilize by the time you're 25. They may even start decreasing in size by the time you're 25. And so you probably don't need it anymore if once you've passed 25. I don't rush to do it on the moment you turn 25 years old. We stop the everolimus in one fell swoop, not at all, but it's, in the late 20s that we start talking about, oh, let's try decreasing the dose, and then eventually stop it. We do the same thing for the kidney tumors, but don't do it. We're not in a rush to do it either. But we have patients where if we've started them on everolimus for their kidney tumors, if it's now been 4, 5 years that you've been on everolimus for your kidney tumors, well, and if they're now very, very small, well, maybe it's time to try and decrease the dose. Decreasing the dose is actually fairly easy for us to do because even small doses tend to be quite effective, actually. You down to 2.5 milligrams and the kidney tumors still don't budge. But then we will start alternating days, or we'll do periods on and off. So on for 6 months, repeat the MRI as long as the kidney tumors are still small, then we'll wait another 6 months. And we definitely do that. Because otherwise, the default option is we're going to keep them on this. It's not a heavy chemotherapy agent, but it is still a light chemotherapy agent. And so you're going to keep that person on it for 10, 20, 30, 40, 50 years without ever trying to do anything else. is our thought process. And we know that we're going to be following these individuals carefully in any event. Something else that happens in adults, I don't think it happens as much in kids, is there are some rare manifestations that can pop up, and so we have to keep an eye on this. So, for instance, neuroendocrine tumors of the pancreas. They usually don't cause too many problems. I have a few that we're following right now with my colleagues in general surgery. Um, but they do need you have to be aware of them. And it's one of the reasons why when we're imaging the kidneys, we don't just stick to the kidneys, we actually image the entire abdomen to make sure that we're looking at the pancreas, that we're looking at the liver as well. It's rare that, but sometimes you can actually get cancer in the kidneys. Quite rare. It's 1 or 2%, but it's something to keep in mind. And that's why once in a while you can't just base your diagnosis of what you see in the kidneys on the MRI. Every once in a while, not too often, but every once in a while, you do have to do a kidney biopsy. Usually, it's just a needle biopsy. So it's the surgeon will do that, the urologist. But every once in a while, you're doing biopsies of those kidneys, just to make sure it's not one of these exceptions. And sometimes you can get bony injuries. We think, we're not entirely sure, but we think that they're related to the bone lesions. That can happen in TSC. Not to talk too much longer, I think I only have a couple more slides. Something else that we think about and talk about in TSC in adults that I would assume is talked less about in kids is about having children, family planning. And so it's a conversation that I have not infrequently with my patients. So it is important to emphasize how it is an autosomal dominant disease. We assume it's always autosomal dominant, even though the genetics may be slightly more complex than that. And so the assumption is that every person who has TSC, there's a 50% chance they'll pass it on to every one of their children. So and each time it's 50-50. And it's not 50-50 overall, it's 50-50. And so that means you could end up where all of your kids have TSC, all 4 out of 4. That can happen. It depends on, the luck of the luck of the draw each time you're flipping that coin for each child. And it's important to understand that it's very difficult to the correlation between the severity in the affected parent and the affected kid. The correlation in terms of disease severity is not very strong. So it is not uncommon to have a mildly affected parent and a severely affected child. I have many patients like that. And so it's important to talk about this in your patients because there are things that can be done. So I refer a lot of patients to a genetic counselor. It's ironic. I rarely refer my patients. Well, that's not true, but I don't refer my patients to the geneticist, the doctor who specializes in genetics too often, unless I need his help in screening a family. I send them much more often to the genetics counselor who works with them because they need the counseling. They don't need the geneticist. We all know they have TSC. What they need to talk to someone about is to better understand what they can do about family planning, about having kids. Is IVF an option? Prenatal screening. There are many options now for people with TSC to have kids if they choose to understand or control whether their kid will get it as well. Contraception is something not to forget about as well. As I had already mentioned, we need to avoid as much as possible. We make exceptions because it's always a matter of risks and benefits, that's certain. But we certainly prefer to avoid extra hormones. So estrogen containing pills, especially. Progesterone, there are certain pills that only have progesterone in them. The other hormone, the other female hormone, they tend to give more side effects. They're actually far less popular, but they are probably safer. And so that's an option. Or the implants or the Nexplanon is only progesterone. But what we usually recommend is an intrauterine device, whether it's copper eluting, hormone eluting, or in copper. Um, those are considered the safest option. And they're also the easiest option in the context of epilepsy. And finally, just to mention that an issue with adults with TSC can be transition. So that learning to live with as an independent adult, but also having a chronic disease, your epilepsy, your TSC, and so helping to support people during that transition period is something else that we think about on the adult side. And that's it. These are just photos of the epilepsy team here at the CHUM. So this is us